Histrionic Personality Disorder. Prevalence of histrionic personality disorder. Most individuals express histrionic personality characteristics either in form of chronic or maladaptive. Inadequate data derived from the overall population surveys indicate its prevalence ranges from 2% to 3%, although structured evaluation of inpatients as well as outpatient in a mental health setting indicate a rate of 10% to 15%. Patient's characteristics. Women with histrionic personality disorder are literary self-centered, largely dependent on others, and self-indulgent. Consequently, they are emotionally labile, so they often inappropriately express intense anger. In addition, they may intimidate suicide as a form of manipulative intent. Men with histrionic personality, on the other hand, commonly display impulsiveness in their inclination to utilize their physical indications. Usually, such urge qualifies as an antisocial tendency and often translates to promiscuity, in which the patient is involved in many sexual relationships. Parent with this disorder often applies manipulative behaviors to shift their children's attention to meet parental expectations. By so doing, they are able to skip parental responsibilities at the same time portraying a loving and concerned impression. Hence, this act can lead to the exploitation and abandonment of their children, which can expose them to emotional, sexual, and physical abuse. Comparison with other personality disorders. The clinical symptoms of histrionic personality disorders are often confused with those of other personality disorders. Hence, it is very crucial to differentiate amongst these personality disorders. If a patient presents a personality behaviors that correspond with a single or more personality disorder besides the histrionic personality disorder, all the disorders should be diagnosed. Borderline personality disorder can also be signified by manipulative behavior, attention-seeking, and abrupt emotional swings. However, it can be differentiated by chronic, in-depth sensations of emptiness and identity crisis, angry disturbance in close relationships, and self-destruction. On the other hand, histrionic personality disorders and antisocial personality disorders share a propensity to impulsiveness, manipulation, excitement-seeking, superficiality, and seductiveness. Although histrionic personality disorder can be distinguished by a trend to be more concentrated in their emotions, while they don't express antisocial characteristics. Characteristically, histrionic personality disorder patients are distinguished from those with antisocial personality disorders by virtue of manipulating to gain nurturance as opposed to gaining power, profit, or any other form of gratification. Histrionic personality disorder patients are willing to be perceived as dependent or vulnerable in order to attract attention, converse to those with narcissistic personality disorder who crave praise for their superiority. Further, the distinction between narcissistic personality disorder and histrionic personality disorder lies in the fact that patients with this disorder may overstress the closeness of their relationship while they are inclined to stress the VIP position or wealth of the person. Moreover, patients with dependent personality disorder are distinguished from histrionic personality disorder patients by virtue of being extremely dependent on others for praise and instructions, as opposed to the flamboyant, embellished, emotional characteristics seen in the latter. The clinician must note the difference between the histrionic personality disorder and personality change due to a general medical condition arising from the primary effect of an overall health condition on the central nervous system. In addition, he or she must be able to distinguish the symptoms of the histrionic personality disorder from those that present due to chronic substance abuse, especially cocaine-related disorder. Diagnosis. A pervasive form of attention-seeking and extreme emotionality, apparent by preliminary adulthood and expressed in various circumstances, is indicated through a number of distinct behaviors, including uneasiness in a context where another person other than him or her is the center of attraction. Interaction with people often inclines towards improper sexual seduction or provocative behavior, portrays abrupt swings and superficial emotional expression, consistently attracts attention to self. Using physical appearance, adopts a speech technique that is overly impressionistic at the same time deficient in detail, depicts exaggerated emotional expression, theatricality, and self-dramatization, being suggestible, in the sense of being easily influenced by people or situations, exaggerates the intimacy of their relationship than they essentially are. Treatment. Interventions which are based on actual and realistic evaluation of events and problems are important. Solution-based therapy is usually appropriate for this patient. Generally, therapy interventions should not be directed towards long-term personality modification, but instead on short-term improvement of the quality of life. Histrionic personal disorder patients promptly seek treatment while exaggerating their symptoms and functional impairment. These patients often express reluctance to therapy termination due to their urge for emotional support. This situation should be circumvented by setting an agreement on the extent of the prescription regimen. Generally, therapy should be supportive as that good rapport will be effortlessly developed with the client soonest. Often, clinician may be placed in the position of rescuer where he or she will be expected to consistently reassure and relieve the patient from constant disturbances. Traditionally, every mental case should portray in a dramatic way. The suicidal inclination is very common amongst patients of HPD, such that there is a need for constant assessment of the patient for suicidal threats, which demands prompt address of the situation. Noteworthy, suicide sometimes follows what was apparently intended to be a gesture, implying that all such conceptions and plans should be accorded serious attention. In addition, self-mutilation acts may also present in HPD and must be regarded as an important agenda in a concession concerning therapy. Nevertheless, the application of suicidal threats should not be an excuse for the client to sustain therapy beyond the realistic limits. Clinicians are encouraged to take a skeptical position in regard to this psychotic population on the grounds of their tendency to exaggerate symptoms and crises the patient may express. This may trigger the patient go through series of reasoning and a realistic conclusion which may reveal impractical expectation and anxiety linked with various characteristics and beliefs. Cognitive and insight-based therapy is often unhelpful because patients with this disorder are commonly unable to evaluate unconscious drives as well as their perceptions. Facilitating the patient to assess interaction from a more objective perspective at the same time focusing on optional reasons for behavior is more useful. Moreover, assessment and clarification of patients' emotions are a worthy aspect of treatment. Group and family therapy interventions are not encouraged because the patient normally craves attention by exaggerating all their moves and responses. Victims of this psychological condition often are portrayed as phones in their interpersonal association with people.